Assalamualaikum warahmatullahi ta'ala wabarakatuhu and good day, sir. I will be discussing the pathophysiology of acute ischemic stroke. So before we proceed, let me explain the legend or color coding used in the illustration so it will be easier to understand the flow. For the black boxes represents the risk factors, violet boxes represent the etiology, while pink boxes represent the disease process, yellow boxes represent the signs and symptoms, green boxes represent assessment and diagnostics, orange boxes represent the medical management, while the blue box represent the nursing management. So, I will now explain how the disease process starts. So, eventually, it will lead to acute ischemic stroke. So, including the related signs and symptoms, assessment, diagnostics, and management. So, acute ischemic stroke begins with several risk factors, which may be classified as modifiable and non-modifiable. So, for non-modifiable risks, we have the advanced age. Aging vessels lose elasticity and are more prone to atherosclerosis. Sex is hormonal and genetic factors can affect risk in both males and females. Family history, which leads to genetic predisposition to hypertension, dyslipidemia, or clotting disorders. So for the modifiable risk, we have the hypertension, which damages the blood vessels and promote clot formation. For high cholesterol, it leads to the plaque buildup and arterial narrowing. For the diabetes mellitus, which causes vascular damage and increased clot risk, and smoking, it promotes vasoconstriction, endothelial damage, and platelet aggregation. Obesity naman is linked to hypertension, diabetes, and dyslipidemia. We have stress. It raises the blood pressure and clotting tendency. For excessive alcohol intake, increases blood pressure, arrhythmias, and coagulation changes. So these factors contribute to damage of blood vessels and increase the risk of clot formation. The disease process of acute ischemic stroke begins with when thrombus or embolus formation occurs. So usually it is followed by the atherosclerotic plaque rupture. Nagli-lead siya. It leads to cerebral artery occlusion, and then when it leads to the artery occlusion, nagre-result siya ng decreased cerebral blood flow. Naapektuhan niya yung brain natin. Okay. So, to the affected area of the brain. So, because of the reduced blood flow, there is a significant decrease in oxygen supply at the ischemic core. So, while surrounding the tissue known as the penumbra, it experiences a slightly reduced oxygen supply. Okay, so we also have this. We have the first one here is the facial drop, the right-sided arm weakness, slurred speech, difficulty speaking, and focal neurological deficits. Okay, so due to inadequate oxygen delivery, the brain cell shift to increase anaerobic metabolism, which is here. And when that happened, which also caused decreased ATP production. Okay, so at this point, the brain requires more energy than the available ATP can provide. So here, as ATP level fall, the sodium-potassium, which is the sodium-potassium pump, stops working properly. So this causes the sodium ions to accumulate inside the neuron. So diyan napapasok yung sodium na build up inside the cell. So followed by the water entering the cell along with the sodium. Okay, so widespread cellular swelling results in cerebral edema. So, nag-lead siya ng compression of vessels and surrounding tissue, damages blood-brain barrier. So, after that, mag-increase na naman yung permeability of blood flow-brain barrier. So, okay, so as a result, immune cells enter the brain tissue from the bloodstream. So, once immune cells enter the brain, they release inflammatory cytokines. So at the same time, microglia become activated to clear damaged cells and debris. So and magre-release siya ng more inflammatory response, so which is the inflammatory cytokines. And then these cytokines then activated astrocytes. Normally kasi, astrocytes absorb glutamate using sodium. So, however, during ischemia is nagre-reverse po yung transport mechanism. Kaya, hindi na ma-absorb ng astrocytes ang glutamate. So, as a result, naiipon po ang glutamate sa labas ng cell. And then, when ATP production decreases, pag bumaba yung ATP production, the sodium-potassium pump fail. Okay, so as a result, yung sodium accumulates inside the neuron and water follows. So, causing a cellular swelling. So, magkakaroon po ng water retention sa neuron ng isang pasyente na nagkakos siya ng cellular swelling. So, then the membrane becomes depolarized, allowing excessive calcium to enter the cell. So, while potassium leaks out, this abnormal depolarization causes neurons to become pathologically activated, leading to excessive release of glutamate, which then accumulates in the extracellular fluid. And when there is a slightly reduced oxygen supply in the penumbra area because of inadequate oxygen and glucose, neurons cannot produce enough ATP. So, as a result, na naman is normal ion pumps fail, leading to abnormal electrical activity spreads from the damaged core area through the exact mechanism is not fully understood. This abnormal activity causes increased chemical reactions in the brain, particularly the excessive release of glutamate, which is the main excitatory neurotransmitter. So, due to injury and astrocyte dysfunction, glutamate is not cleared properly, so causing it to accumulate outside the cell. So, the excess glutamate then overstimulate glutamate receptors on neurons. So, when these receptors are activated, they allow a large amount of calcium to enter the neuron. So, this calcium overload triggers destructive processes inside the cell, including the activation of enzymes that break down proteins and DNA. So, this results in dysfunctions of neuronal protein synthesis activity. So, leading to neuronal cell damage and eventually neuronal cell death. As neuronal death progresses, the volume of the dead brain tissue increases, while ongoing inflammation of the brain tissue further worsens the injury. So, all of these interconnected processes results in ischemic brain injury and a clinical manifestation of acute ischemic stroke. Once these clinical signs are recognized, immediate assessment and diagnostic evaluation are performed. Okay, so the fast assessment used for rapid identification of stroke symptoms and early activation of the stroke protocol. Neurologic assessment determines the severity of neurologic deficits and establishes the baseline for monitoring progression or improvement. Non-contrast CT scan of the brain differentiates ischemic stroke from hemorrhagic stroke, which is crucial before administering thrombolytic therapy. Of course, we have to monitor blood glucose. Hypoglycemia can mimic the stroke symptoms and must be ruled out immediately. We also have the CBC and the WBC, assess for infection, anemia, or platelet abnormalities that may differ and that may affect treatment decisions. Next one is the electrolytes imbalance, which can worsen neurologic function and must be corrected. For the blood pressure naman, ensure adequate cerebral perfusion while preventing complications such as hemorrhagic transformation. So, cardiac monitoring detects arrhythmias that may be the source of the embolic stroke. So, let's proceed to the medical management, focusing on restoring cerebral blood flow and preventing the brain damage. Okay, so we have the IV thrombolysis therapy. So, it dissolves the clot to restore perfusion. So, if the patient is within therapeutic time window. So, mechanically thrombectomy, remove large vessel clots. Antiplatelet therapy prevents future clot formation. And permissive hypertension maintains cerebral perfusion. And for the oxygen therapy, it optimizes the oxygen delivery to the ischemic stroke. Okay, so nursing management is essential in preventing complication and supporting recovery. Deactivate stroke protocol immediately, ensures rapid diagnosis and timely treatment, improving patient outcomes. Next one is we have to maintain airway and adequate oxygen. It prevents hypoxia, which can worsen cerebral ischemia, and elevate the head of the bed to 30 degrees. It promotes venous drainage and reduces intracranial pressure. Keep the patient NPO to prevent aspiration. Prevent aspiration due to impaired swallowing reflex. Monitor vital signs and neurologic status frequently to allow early detection of deterioration or complication. Also, establish IV access, provides a route for medication, fluids, and emergency intervention. Avoid hypotonic fluids, prepare patient for urgent CT scan, prevent complications such as aspiration, DVT, and pressure injuries, promote patient safety, and prevent secondary brain injury. Okay, so it minimizes the risk or falls, increase intracranial pressure, and further neurologic damage. So, if acute ischemic stroke is left untreated, the progressive neuronal death may occur, leading to severe permanent neurologic disabilities or even death. So, that would be all for the pathophysiology of the acute ischemic stroke. Assalamualaikum warahmatullahi ta'ala wabarakatuh.
Everyone, we will be presenting a demonstration about a patient experiencing an acute ischemic stroke. So the patient is a 68-year-old female, suddenly developed slurred speech, facial dropping, and right-sided weakness while at home. So these signs indicate a disruption of blood flow to the brain, resulting in decreased oxygen supply to the brain tissue. So this scenario highlights the importance of early recognition, rapid assessments using the FAST method, and timely nursing, medical, and surgical management. So through this, we will demonstrate how coordinated care helps prevent further brain damage and improves patient outcomes.
Nurse, nahihirapan po ako magsalita at saka mabigat po ang braso ko.
So good day, ma'am. I am Nurse Sharif. So now I will assist you.
Ma'am, please try to smile. And ma'am, please, pwede po niyo po bang itaas niyo yung dalawang kamay niyo po? Sundan niyo po yung sinasabi ko, ma'am. The curtain is pink. The curtain is pink.
The patient has a facial drop, arm weakness, and difficulty speaking. Past assessment is positive. Okay, based on the sudden onset of symptoms and assessment findings, the patient is diagnosed with acute ischemic stroke.
As nurses, our priority is to stabilize the patient and prevent further brain injury. So we ensure airway, breathing, and circulation. We elevate the head of the bed to 30 degrees, and we monitor the vital sign and oxygen saturation, and we keep the patient NPO to prevent aspiration, and we establish the IV access and perform frequent neurological checks. The medical management focuses on restoring cerebral blood flow. An urgent CT scan is done to confirm ischemic stroke. If eligible, the patient may receive IV thrombolytic therapy within 4.5 hours. Antiplatelet therapy may be initiated if thrombolysis is not indicated. Blood glucose and blood pressure are closely monitored.
If a large blood vessel is blocked, surgical intervention may be required. Mechanical thrombectomy may be performed to remove the clot. And then this is ideally done within 6 to 24 hours based on imaging result. So nurses provide pre and post-procedure care and close monitoring.
After acute management, continued nursing care is essential. So we assess with mobility and prevent complications. We monitor for signs of increased intracranial pressure, and we provide emotional support to the patient and family, and we also educate on stroke warning signs and lifestyle changes.
Early recognition and coordinated nursing, medical, and surgical management improve outcomes in patients with acute ischemic stroke.